We're going to spend a little time talking about electrocardiography. And, I looked up what REBEL stands for, and I know it stands for evidence-based evaluation. And this, I have to tell you right up front, this is not going to be primarily a research-based talk. Unlike George's talk, I'm not going to take you through a lot of different articles. I know it's late morning, and on a Saturday, probably a lot of you feel a little bit like this. So we're just going to do essentially a visual diagnosis lecture as we go through this. And in the next 30 minutes, I hope to teach people and really pound into everyone's heads two very simple findings. And I'm going to show you case after case after case after case until you're sick of this, so that, but at the very least, until you really know these two simple visual diagnosis findings. And this is all very case-based. All of the cases I'm going to present to you are real emergency department cases, and they have to do with the T wave, a part of the electrocardiogram that I think doesn't get a lot of respect, but I think after today, if you pay more attention to that T wave, you're going to pick up some early cases of cardiac ischemia, some subtle T's, as I say, of cardiac ischemia. So we're going to start with this case. This was actually sent to me by a former residency graduate, Sean Fox, who's an outstanding educator down at Carolinas Medical Center. He was working in a terribly, terribly busy day, busy shift. Every bed's full. Paramedics arrive with the 48-year-old guy who's got some atypical chest pain, and of course there's no bed. So they park him in the hallway, and they get a 12 lead while in the hallway, and here's the 12 lead, and I'll ask you to just take a look at this, and what would you do with this patient? The pain's atypical, his pain is relatively mild, and the ECG machine is really not calling this anything of concern. But there was something on this 12 lead that had Sean a little bit concerned. And also the patient was having just a little bit of pain during this 12 lead. And I'm going to put the time up here because that's going to be important. And what Sean was specifically worried about was a very subtle T wave abnormality in lead V2, because he's learned that the normal T wave in V2, or really anywhere, should be concave upwards and go into the T wave. And in this particular case, you'll notice that what has been lost is the upward concavity. Instead, what you're ending up seeing here is that the initial part of the T wave has become very straight, and you get a hint of that in V3 also. Now, are you going to activate the cath lab for this? Absolutely not. You're going to get yelled at by your cardiologist if you try to do that. And there's really no ST segment elevation either, but there's something abnormal about that T wave. So when you see a subtle abnormality, something that might be abnormal in somebody, especially who's having some cardiopulmonary symptoms, what do? Well, very simple. You repeat the 12 lead and see if something evolves. If nothing evolves, fine. Maybe you all are off the hook. But maybe something will evolve. So that's exactly what he did. He gets a repeat 12 lead about 10, 15 minutes later. And now you can see that that T wave has become just a bit more straight. And it almost looks like maybe there's a little bit of J point elevation now. Well, you're going to activate the cath lab for this? No, of course not. It doesn't qualify for cath yet. I think most of us would probably not. Maybe V3 is changing just a little bit also, but gosh, it's really subtle. What are you going to do? How about we repeat it again? So that's what he did. 2 minutes later, he gets another 12 lead, and it looks a little bit different again. In fact, let's take a look at what those T's look like. I'm going to put the first ECG and the third ECG next to each other, and you can see that at 2:35, there is the T wave in V2 and V3, and then we'll move it over, and now take a look. It's gotten a little bit different. It's subtle, and it might not buy you a trip to the cath lab, but something is changing. And the other thing that you'll also notice is that not only is that T wave becoming more and more straight, and the J point seems to be rising a little bit, but you've got this little terminal inversion at the end of the T wave. And you remember what it's called when you've got a biphasic T wave in the mid-precordial leads? That's called Wellens waves. And that's what these arrows are pointing out, this little terminal inversion at the end of the T wave out there. Those are called Wellens waves, and they often predict a proximal LAD occlusion. Gosh, that's really subtle, but it's different. Same ECG machine, same ECG lead placement. Things should not change if this is benign, and things are changing. So what he does is he gets another 12 lead a little while later, and now, again, very clearly, those STs are starting to rise. Take a look at V4. V4 now has become biphasic as well. So at this point, he goes ahead and calls cardiology, and right before the patient goes up to the cath lab, he snaps one more 12 lead, biphasic V4, biphasic V3, ST's gotten higher and you've got a little bit of Wellens up there in V2. And what do you think ends up being found on the cath? Of course, 95% proximal LAD occlusion. And it all started with Sean just noticing a very subtle change on the initial part of that T wave. It became straight instead of concave upwards. And that's something that we're going to really, really harp on. Again, that's oftentimes an early finding in cardiac ischemia. When I was in residency, I remember working with a cath attending, the head of the cath lab at Jefferson, where I did residency. And he said that when a patient develops ischemia, the first thing that happens is not that the STs start to rise. The first thing that often happens is the T wave starts to change. It either becomes tall and broad-based, what we oftentimes refer to as hyperacute, which we'll talk about later, but the other type of hyperacute T wave is when the initial part of that T wave becomes very straight. So normally the T wave should be nice and concave upwards, but when it moves into this morphology of shooting straight out, that straightening needs to worry you, because the next thing that's going to end up happening is it's going to become more of a tombstone. I'm not a great artist here, but it's going to become, boy, that's really bad. It's going to become a bit more of a tombstone, and that's going to be very obviously a STEMI. But before you get to this point, you've got to be able to recognize that straightening on the initial part of the T wave. And when you see that, worry about early ischemia. And what do? Simple. Just repeat the 12 lead in 15, 20 minutes, 30 minutes. Just at some point get another repeat, and you're going to find a lot of these patients end up turning into early STEMIs. So I want to spend some time talking about this T wave. Again, I think this is one of the most underappreciated part of the EKG. I often refer to this as the Rodney Dangerfield finding. I've referred to AVR before also as the Rodney Dangerfield lead, but the Rodney Dangerfield part of the EKG is the T wave. Everyone pays attention to the ST elevation, the ST depression, the Q wave, the P wave, but the T wave gets no respect. And after today, you've got to respect the T wave. And I just sat down and made a list of all the different things that the T wave gives us information about. Take a look at all these things that the T wave can help us identify. And today we're just going to focus on this concept of hyperacute T waves to really, really hammer this home. And there's two types of hyperacute. The first type that we're going to spend time talking about is when that T wave becomes very straight and shoots straight out. It's not supposed to do that. The initial part of the T wave is supposed to be concave upwards, nice, gentle concave upwards. But when it shoots out, and I often refer to this as the BAM finding, take a listen to what happens when I'm drawing this. T wave is about to start, and bam! So when you hear the BAM, you put that EKG right up to your ear and you hear the BAM. When you hear that, when it shoots straight out like that, you've got to worry about early ischemia until proven otherwise. And how do you prove otherwise? Just repeat the 12 lead and see if something evolves. This is the traditional hyperacute finding that everybody learns about. Everybody learns about this tall, broad-based T wave, and we'll get to that in a little bit. But I want to focus your attention instead on the morphology. Take a look at how straight the early ischemic T wave finding is. Here's a missed case from our own emergency department. This is a 69-year-old woman who presented with very atypical findings. So she sat out there at triage and then got put in the waiting room after this 12 lead, the 12 lead that's got bad baseline. And the computer just called this non-specific. But what was missed on this is the fact, again, there's a very straight initial part of that T wave in V2 and V3. That's not normal. The other thing that's not normal that we'll talk more about is take a look at how tall those T waves are. And what I say is that if you ever have a T wave that is so large that you can take the entire QRS and fit it inside the T wave, that is abnormal T wave. We'll talk more about that in just a little bit. But right now I want to focus your attention on how straight those T waves are. That's not normal. They should not be so straight. And when they are straight, you've got to worry about early ischemia. Even though there's no ST elevation yet, you've got to worry about early ischemia. By the way, this is the patient's baseline. This is the way the T waves are supposed to look. Nice and concave upwards. But what did we just see? They became very straight. And that's an early sign of ischemia. Anyway, what happened with this patient, several hours later, a bed opens up. She finally gets brought back to the bed, and by now it's too late. The patient has already infarcted and queued out across the precordial leads, and she ended up with a significant cardiomyopathy with the loss of myocardial tissue. It could have been identified several hours earlier. Let's look at a few more cases just to really hammer this home. Here's a 44-year-old man who comes in with chest pain, and take a look at this. You know, there's some ST segment depressions in a handful of leads. This is a piece of cake admission to the hospital. And in fact, here's the baseline, all right? But what really disturbed the physician about this 12 lead was the hyperacute T waves, very, very straight. They're not supposed to be straight like that. And again, if we look at the baseline, that is what they're supposed to look like. All right, but now they're very straight. Now, a bed's ready upstairs. This patient can easily be admitted for acute coronary syndrome because of the ST depressions out there. But instead, what the physician did was he said, you know what, let's just check one more 12 lead before the patient goes upstairs. And they got one more 12 lead before the patient went up to telemetry, and here's the repeat. It's turned into an anterior STEMI. So instead of going up to a bed, the patient goes straight to the cath lab. This ECG was obtained about 40 minutes, 45 minutes later. And that's a life saved, because what would have happened? The patient would have gone upstairs to a bed and just sat there infarcting until finally, maybe the next morning, they get around to repeating the 12 lead. You know, I always say that the best place to have a STEMI is in the emergency department. If you're going to turn into a STEMI, I want it in the emergency department, because there's no place in the hospital that is better greased to get patients proper treatment than the emergency department, even probably better than the CCU. So if you're going to repeat that 12 lead and look for a STEMI, do it in the emergency department before they go upstairs. Here's another case. Take a look at this. And in this particular case, the physician again saw some ST segment depression, piece of cake admission. But the physician took a look at the baseline, and the baseline, or rather the physician took a closer look at V3 and found that this is very, very straight. That's not supposed to be straight. This is a type of hyperacute T wave. Notice again, hyperacute doesn't necessarily mean the T wave has to be big and tall. It simply can be straight. And when it's straight like that, you've got to worry. And he repeats the 12 lead about 30 minutes later, and bam, there's your anterior wall STEMI. Here's another case, 60-year-old man. And this is pretty easy because this patient already has ST elevation in one in AVL. This is a high lateral STEMI. But I show this to you just to really, again, hammer home the fact that the straightening is an indication of early cardiac ischemia in these patients. So when you see straightening, you've got to worry about it. We're not done yet. Let's keep on hammering this home. Take a look at this 52-year-old woman with chest pain, and the computer's going to call this non-specific T-wave abnormality. Why? Because there's not more than a millimeter of ST elevation in two contiguous leads, so the computer will call it non-specific. Well, there's probably about a millimeter of elevation here, but there's not a millimeter in the contiguous leads. But what you do notice, take a look at how straight these are in all of your inferior leads. That's a sign of early ischemia. There's also reciprocal depression in AVL. And again, the machine's going to mislead you. Here's the baseline. This is the way the T waves are supposed to look like, nice and concave upwards, not straight. Well, now you've got straightening. And so what are you going to do? You're going to repeat the 12 lead. And that's exactly what they ended up doing. You also notice that there's a little bit of this Wellens type of appearance there. They repeat the 12 lead about half an hour later. And now there's a full ST elevation of a millimeter in 3 and an AVF, probably in lead 2 also. And also you're getting some straightening in the anterior leads as well. This turned into a wraparound LAD occlusion, not just an RCA. This is a life saved. You could have sent the patient upstairs to sit on telemetry and sit there and infarct, but no, you got the 12 lead a lot faster than that. Here's a 69-year-old who comes in with chest pain. Again, this is easy to admit. You've got a little bit of ST segment change down here, PVC, 69 years old with chest pain. There's a good chance that patient's going to be coming in if there's any concerns at all. But the main thing that concerned the physician here was out laterally. Again, take a look, straight, straight, straight. It's not supposed to be quite so straight. Here's the baseline. This is what it is supposed to look like. Take a look at that. Take a look at how different these T waves are. Just that straightening is a sign of early cardiac ischemia. So again, I think you can really appreciate how it's become more straight. So what do? You're not going to probably get away with activating the cath lab on this. Maybe you will, but I think most of our departments will probably get cardiology calling back and saying, no, I'm not happy with that. So what do? You repeat the 12 lead, and they repeated it about half an hour, 45 minutes later, and now you've got your anterior wall STEMI. This patient goes up to the cath lab. All right. So again, just to sum this up, this first part, hyperacute T waves. Everybody learns about tall and broad-based, but please be wary of straightening on the initial part of the T wave. When you see straightening, worry about early ischemia and just repeat the 12 lead. If you get a repeat 12 lead and nothing is evolving over, we'll just arbitrarily say over the course of an hour, if nothing's changing during an hour and the patient's actively having pain and nothing's changing, then it's probably fine. But I promise you, before this Rebel EM conference next year, every one of you who does this, you're going to pick up an early STEMI. It's not an everyday thing, but it's common enough that I can almost guarantee everyone listening is going to pick up an early STEMI at some point in the next year because you paid attention to straightening and you repeated the 12 lead and you found something evolve. All right, we'll take a little mental break here. I know people are thinking about lunch, so we're going to continue on, try to get to lunch soon, all right? And we're going to talk about a second type of hyperacute T wave. This is the more traditional. This case was sent to me by Dr. Manimaran from India. This was initially not his patient, but I'm going to show you the patient's initial presentation to another hospital, 60 years old, 1 hour of mid-sternal chest pain, history of hypertension. Here's the 12 lead. And I'm sure everyone's looking for straightening. There's no straightening. You've got nice concave upwards ST segments everywhere. But hopefully what you're noticing is that there is a different type of hyperacute T wave. Take a look at V2, V3, maybe in V4. Those are pretty tall T waves. And people always say, well, how tall does the T wave have to be before you call it hyperacute? For me, it can be a bit of a gestalt, but a very objective way of doing this. One thing that I've learned is that whenever you have a T wave, which is so large that you can take that entire QRS and fit it inside the T wave, that's always abnormal. You should never have a T wave that's larger than the entire QRS. If you do, the two things I'm thinking of are either hyper K or early cardiac ischemia, and your history should help you decide which of those two is going on, and of course, the rest of the 12 lead. So to me, V2 is diagnostic. This patient has ischemia until proven otherwise, but the computer doesn't know this. The computer will not call this. It's very rare I've seen a computer call something hyperacute, certainly based on this. So the computer just called this non-specific at best. You notice there's a tad bit of ST depression out laterally. It's less than 1 millimeter depression. So what does that mean? Your computer will call it non-specific if it's not a full millimeter. Patient ended up being discharged. Again, this is a little blow up of that. This is a normal T wave QRS complex relationship. You should never have a T wave that's larger than the entire QRS. All right, well, anyway, this patient ended up being discharged and then showed up at Dr. Manimaran's hospital. Upon presentation had a cardiac arrest and he was not able to save the patient, but then he went back and got records from the original hospital and found this EKG, which should have been diagnosed as early cardiac ischemia. This patient ended up dying because it was missed. So let's look at a handful more cases. Just again, very simple lecture here, just to really hammer home this finding. Here's an 88-year-old who comes in with upper abdominal pain. Remember, elderly patients oftentimes will have upper abdominal pain as their manifestation of ischemia, 12%. 12% of elderly present with upper abdominal pain instead of chest pain. Don't remember the number, just the concept. Remember, the diaphragm's not a concrete wall. Anything in the chest can produce belly pain. Anything in the belly can produce chest pain. So if somebody has upper abdominal pain and they're not really tender, you've got to worry about thoracic problems, all right? So you get a 12 lead and what do you see? Well, very simple. There's big T waves in V4 and a couple other leads, but take a look at V3. I can take that entire QRS and fit it inside that T wave. Bam, that's abnormal. That can't be normal. It's either hyperkalemia or ischemia until proven otherwise. Well, they actually contacted cardiology and tried to activate the cath lab, and cardiology said, no, there's no ST elevation yet. Let me go back. There's no ST elevation yet, so I'm not going to take them for cath. So what do? You repeat the 12 lead. This was done 35 minutes later, and now you see some PVCs, but now take a look at this. The T wave has gotten even larger in relation to V3. Now V2, same thing in V2. I can fit V2 inside the QRS, and V4, I can probably almost fit that inside. So at this point, they call cardiology back and say, things are evolving. The T waves are looking uglier. Finally, cardiology ends up taking this patient to the cath lab. Just before the patient went up, they snapped one more 12 lead, and take a look. Now, the patient is already queued out or lost the R waves in the anterior leads. Now there's ST elevation. This patient's had an anterior wall infarct. This could have been prevented if the patient had gone for cath right up front. This is about 45 minutes later. And the patient ended up with an occluded LAD. They actually did an abdominal workup, which was negative as well. Next case, this was sent from Kentucky. 71-year-old comes in with an episode of chest pain plus diaphoresis. There's a bad word. I hate seeing diaphoresis. That, to me, again, patients that are sweating, if a patient sweats, it ought to make you sweat. Chest pain plus diaphoresis, you've really got to worry about it. But, you know, take a look. The patient got better with acids. It's probably just reflux, right? Well, we get a 12 lead. And what do you notice on the 12 lead? Now there's a little bit of depression out laterally. And again, a little bit of depression laterally, flip T wave and AVL. But what really struck Dr. Richards here was the relationship between the QRS complexes and the T waves. There's really not much at all ST elevation. This is less than a millimeter, so that the computer at most would call this non-specific. But again, I could take that QRS and fit it inside the T wave there. I can take that QRS and fit it inside the T wave pretty much here as well. These are hyperacute T waves. Hyperacute T waves don't have to be that tall, but you need to compare them to the size of the QRS. And if they're larger than the whole QRS, you call that hyperacute and worry about early ischemia. Well, again, no significant ST elevation, but they went ahead and activated the cath lab. Cardiology took a look at the EKG and said, all right, we'll take him to the cath lab. Honestly, I don't think most of my cardiologists would have taken this patient to the cath lab yet, but at this hospital they did. And much to their credit, the patient had 100% RCA and got opened up really early. So kudos to those cardiologists for taking this patient based on that. Here's a case from a friend in Toledo, Patrick Bruss, 77-year-old with chest pain, shortness of breath, nausea. There's that bad word again, diaphoresis. A few cardiac risk factors up there, hyperlipidemia, diabetes, hypertension. We get a 12 lead and take a look at this. What has you worried here? Well, again, there's some non-specific subtle ST segment junk, but the one lead that's got me really worried here is V2. I can take that QRS and fit it inside the T wave. That's always abnormal. That's either hyper K or early cardiac ischemia. And the history here is not suggesting hyper K. The other leads are not suggesting hyper K. So this is ischemia until proven otherwise. Well, they contact cardiology. Cardiology says there's no ST elevation, so no cath. So what do? Simple. Patient still got ongoing pain, get another 12 lead. And so they get another 12 lead 20 minutes later, and here's the repeat 12 lead. Well, things are changing. Now there's clearly ST elevation, a bit in V1, also in V2. V2 is becoming a bit biphasic. That QRS and T-wave relationship has changed. They call back cardiology and say things are evolving on this 12 lead. Now there's ST elevation in V2. So at this point, cardiology says, fine, 100% LAD on cath. Again, you probably could have gotten the patient to the cath lab a little bit earlier if cardiology had gone for that. Here's another one. Computer calls this totally normal. Again, the computer doesn't know about hyperacute T waves well. But when you look at this 12 lead, there's V2, V3 again. Those are not normal. You've got a T wave, which is pretty much as big as a QRS, and clearly in V2, I can almost, I probably could fit that QRS inside the T wave. That's got to be abnormal. But, you know, computer's calling this normal. Maybe you're not convinced, so what do? Get another one. So Dr. Fairbairn got another 12 lead just a few minutes later. And what did they end up finding here? Well, the T waves are changing, and he gets another 12 lead. Another 12 minutes later, again, T wave morphology is changing. And also take a look, you're developing ST depression here, shooting up into a big, tall, symmetric T wave. Remember what that's called? That's called the De Winter T wave pattern. And so they go ahead and activate the cath lab, and what do you see? 100% LAD occlusion. Here's another case. I hope you're getting bored of this. I want you to get bored of looking at these cases. I want you to know this stuff so well that when that patient shows up in your emergency department, you say, that T wave's too big. Activate the cath lab. Come on, give me something more interesting. That's how well you've got to know this, all right? And your cardiologist may not know this. Your computer won't know this, so what do? Simple, repeat the 12 lead, and you'll see this. One of my colleagues, Doug Sward, and again, the computer is totally missing this. Doug was worried about V4. T wave is way too big for that QRS. So what do you do? Well, he repeats the EKG just a few minutes later. Computer is still missing the STEMI, but now you've got ST elevation, V4, V5, V6. This was a lateral STEMI. And it all started with simply a T wave that was too big. The early findings in cardiac ischemia. Last case, this is a med-mal case that Dr. Vance here, who's a retired family physician, wanted to share. He gave this to me at a conference and said, please share this with everybody so no one ever makes this mistake. He had a 29-year-old who right off the bat, because he's a 29-year-old who likes biking, he thought this can't possibly be cardiac. He came in complaining of some vague chest pain, some other symptoms like that. He got a 12 lead. Computer called this non-specific. And so Dr. Vance discharged the patient. A day later, this patient had a cardiac arrest. And this ended up going to litigation, and he paid out a lot of money for this. And what came up at litigation? Hyperacute T waves. Take a look. I can take that QRS and fit it inside the T wave. That's a hyperacute T wave, all right? Maybe a bit in V4 also, but V3 is not normal. You can't call that normal the way the computer will probably call it, all right? And again, the patient ended up having sudden cardiac arrest a day later. So quick take-home points. Again, beware hyperacute T waves. Please start paying attention to the T waves. They can give you early information that other parts of the 12 lead will not give you. You need to worry about early ischemia when you see T waves that are either too straight or T waves that are too tall in relation to the QRS complex. If you can take in a QRS and fit it inside the T wave, that is never normal. Repeat the 12 lead and prove that it's not evolving. And again, I promise you that this is something that's common enough that everybody out there listening is going to have a case like this show up in your practice at some point in the next year. And that's a life saved, because you're able to reperfuse that patient a little bit earlier and get that patient proper treatment, all right? And what typically happens is that these T wave abnormalities will precede the ST elevation, and your computer is not programmed to pick these up. Don't rely on your computer. Just get in the habit of getting serial ECGs when you see any of these things show up. Well, my thanks again to Salim and also Chris for helping set all of this up. And if there's any questions that come up, please do not hesitate to email me. There's my email, amalmattu@comcast.net. If you have interesting cases you want to share, please do so. And once again, Salim, thank you so much for giving me this opportunity to talk to you and all of your colleagues.